Today we are going to describe the effect of antagonists on cholinergic transmission. First, pharmacology of muscarinic receptor antagonist will be explained, and then pharmacology of nicotinic receptor antagonist on autonomic ganglia, and then at neuromuscular junction will be explained, and we will describe them. These drugs which block nicotinic receptor on the neuromuscular junction, also known as non-depolarizing muscle relaxant. I would like to remind you that antagonists will attach to the receptor and prevent agonist access to that receptor. That agonist is acetylcholine, which is released from nerve terminal. A wide range of muscarinic receptor antagonists are available on the market, possibly more than 50 of them. I have listed most important of them. You will recognize more and more of them during your course of pharmacology. Their common pharmacology properties will be described in here. Atropine is a typical muscarinic antagonist you are familiar with. It is an alkaloid extracted from plant, especially from belladonna. Other drugs include homatropine, hyoscine, also known as scopolamine, both are generic name, toropicamide, dicyclomine, propanthelin, ipratropium, piranzepine, benzoropine, and several others. These agents all produce a competitive antagonist of acetylcholine at muscarinic cholineceptors. By blocking muscarinic receptor, muscarinic antagonists reduce parasympathetic activity on their effector cells. For example, on the eyes, they relax ciliary muscles and paralyze accommodation. Eyes become long-sighted, also known as cycloplegia, because it causes a blurred vision. Relaxation of circular muscle of iris results in pupillary dilatation, known as mydriasis. Muscarinic receptor antagonists inhibit secretion of lacrimal glands, resulting in dryness of eye. On the heart, at resting, usually parasympathetic activity is controlling the heart rate at the SA node level. Therefore, atropine by removing inhibitory effect of acetylcholine on the SA node will cause a mild tachycardia. During exercise, sympathetic activity is dominant. Atropine, by eliminating inhibitory effect of acetylcholine on AV node and the conducting tissues, improves cardiac impulse conduction. Notice that there is no effect on ventricular contractions because there is no acetylcholine release there. On the respiratory system, muscarinic antagonists relax smooth muscle of bronchioles and cause bronchodilation and reduce bronchial secretion. On the gastrointestinal tract, motility of propulsive muscles is inhibited and exocrine gland secretion is reduced. On the bladder, antagonists of muscarinic receptors on the detrusors smooth muscle prevent bladder contraction and cause difficulty of micturition. Although eccrine sweat glands are innervated by sympathetic neurons, however, if you remember, the postganglionic neurons are cholinergic and receptors are muscarinic. Therefore, muscarinic antagonists prevent sweating, causing skin dryness. Generally, it can be said that muscarinic antagonists reduce exocrine gland secretion. In clinical practice, muscarinic cholineceptor blockade is more readily produced in some organs than in others. The order of susceptibility to blockade is sweat, bronchial, and salivary glands, and then heart and muscle of eyes, smooth muscle of bladder and GI tract, smooth muscle, and at last gastric glands are affected. Clinical use of muscarinic antagonist on the cardiovascular system. Sinus bradycardia, which sometimes happens after myocardial infarction, can be treated with atropine. On the respiratory system, bronchoconstriction of chronic bronchitis, ipratropium by inhalation is a useful treatment. In hypothalamic examination. In diagnostic retinoscopy, in order to dilate the pupil, toropicamide eye drops is used as a routine mydriasis. It is a mydriatic drug, and toropicamide is a short-acting mydriatic agent compared with other antagonists, and that's why it is chosen for dilation of pupil, because after the examination is over, you don't want that your pupil to remain dilated. In conditions such as iritis or iridocyclitis, these are inflammatory conditions in which iris tend to adhere to the surface of lens. In this situation, a mydriatic drug with long action is preferred. For example, atropine eye drop or hyoscine eye drop or homatropine eye drops. On the gastrointestinal tract, dicyclomine or propantolene are used as antispasmodic drug for irritable bowel syndrome or colonic diverticular disease. To prevent peptic ulcer disease by suppressing gastric acid secretion, piranzapine, which is an M1, which is a M1 selective antagonist, reduce gastric acid and pepsin secretion and thereby promote ulcer healing. Hyoscine is used to facilitate endoscopy and gastrointestinal radiology by relaxing GI tract smooth muscle. Hyoscine is also used for prevention of motion sickness. It is a central nervous system effect. Another useful central nervous system effect of muscarinic antagonists are for treatment of Parkinson's disease, especially to counteract a movement disorder caused by antipsychotic drugs. Drugs which have more penetration into the CNS, like benzhexol, benztropine, piperidine, are used to control tremor and excessive salivation in Parkinson's disease. Another name for benzhexol is trihexylphenydyl. Both are generic names. As you know, in a stratum of Parkinson's patients, there is a shortage of dopamine relative to acetylcholine. One way to restore balance is to reduce acetylcholine activity by benzhexol. Hyoscine and atropine are used also as an anesthetic premedication to prevent bronchial secretion induced by inhalational anesthesia. In addition, mild tachycardia produced by these drugs contract with bradycardia induced by anesthetic drug. Muscarinic poisoning resulting from ingestion of mushroom containing muscarine. In this situation, atropine is a specific antidote. Atropine is also used for protection against undesired effect of anticholinergic agent during anticholinergic therapy in myasthenia gravis, or poisoning with organophosphorus agent, as explained in previous lecture. Other applications include treatment of hyperhidrosis. This is abnormally excessive sweating that's not related to heat or exercise. And also for relieving of bladder spasm, oxybutynin or propantolin are useful. As you noticed, muscarinic antagonists have many diverse effects. Depending on condition to be treated, some of these effects might be useful and others are considered as unwanted effect or side effect. Some side effects of the muscarinic antagonist are predictable. Suppose you give Eucin for travel sickness. It causes cycloplegia. Patient has a blurred vision. And long-sighted. It causes photophobia. The patient cannot tolerate intensive light because pupil cannot constrict. Patient also has dry eyes, dry skin, and its heartbeat has gone up due to tachycardia. And in long-term treatment, it will be constipated because motility and secretion of gastrointestinal tract is reduced. Another problem is urinary retention, especially in patients with prostatic hypertrophy, therefore contraindicated in patients with hypertrophy of prostate. Another problem, particularly in the elderly, is risk of precipitating glaucoma due to paralysis of ciliary muscles. Therefore, all muscarinic antagonist receptors are contraindicated in patients with history of glaucoma or prostatic hypertrophy. Atropine has two other activities that cannot be explained in the term of blockade of parasympathetic activity. It causes histamine release, which results in dilatation of cutaneous vessels. In therapeutic doses, atropine stimulates the medullary vagal center to evoke a transient bradycardia. This precedes the tachycardia due to occupation of myocardial muscarinic receptor by atropine. That's why it's called a transient action. In toxic doses, it causes restlessness, excitement, hallucination, delirium, convulsion, and even death. Now we are going to describe nicotinic antagonists. First, nicotinic blocking drugs. Hexametonium, tubocurarine, trimetophan, mecamylamine. These are competitive antagonists at nicotinic receptor of ganglia. By blocking the receptor, these agents prevent interaction of the acetylcholine with the nicotinic receptors at the ganglia and therefore reduce excitability of postganglion neurons. Hexametonium is a selective antagonist at nicotinic receptor at ganglia. It has no effect on nicotinic receptor at neuromuscular junction. These drugs block transmission through all ganglia, both parasympathetic and sympathetic neurons, and also at the adrenal medulla. However, these agents have little therapeutic application because their effect in the whole body is so diverse, except trimetophan, which is used occasionally to produce controlled hypotension in operation room. Trimetophan is given by IV injection to lower blood pressure and thereby minimizing bleeding at the site of injury. It can be controlled by tilting bed head. In addition to ganglionic blockade, trimetophan can lower blood pressure by direct relaxing vascular smooth muscle and by evoking histamine release. Now we are going to describe the effect of nicotinic antagonist on neuromuscular junction. Tibocurarine is also an antagonist at neuromuscular junction. By reducing the interaction of acetylcholine with its receptors, this drug reduces the depolarization and reduces the amplitude of action potential. If the end plate potential no longer crosses the threshold of excitability, neuromuscular transmission will fail. Effect on fast twitch fiber and slow twitch fiber is similar with nicotinic antagonist on neuromuscular junction. Unlike succinylcholine, there is no fasciculation or muscle pain. Choline extracted from plant material was first known muscle relaxant. Tubocholine is originated from choline. Other drugs like galamine, pancuronium, vecuronium, procuronium was discovered after tubocholine. These are competitive antagonists at neuromuscular junction and useful for producing muscle paralysis during surgery. They allowed the anesthetist to employ a relatively light level of anesthesia and yet have adequate muscle relaxation. In all cases, there is a need to ventilate the lungs. Tubocholine causes histamine release and ganglion blockade and hence lowers blood pressure. This is not a problem with pancuronium, vecuronium, or procuronium. Galamine is clinically obsolete because of cardiovascular problem associated with its use, so it's no longer used clinically. Alpha-bungarotoxin is a component of venom of a snake. It binds irreversibly and very selectivity to the nicotinic receptor of skeletal muscle. It is not clinically useful, but it is very valuable research tool for localization and isolation of nicotinic cholineceptor of skeletal muscle. Atracorium is useful in patients with impaired kidney or liver function because its inactivation is largely brought about by spontaneous dissociation. A spontaneous degradation takes place in plasma and in tissue. However, it causes histamine release and therefore lower blood pressure and cause bronchoconstriction. These are effects of histamine. Cis-atracorium is a single isomer of atracorium. It is more potent and has a slightly longer duration of action. It provides greater cardiovascular stability because it lacks histamine releasing effect. Pancuronium has a long duration of action. It is useful in patients requiring long-term mechanical ventilation. Pancuronium lacks histamine releasing effect. Vecuronium has an intermediate duration of action. It does not produce histamine release and lack cardiovascular effect. Rocuronium exerts a relaxant effect within 2 minutes and has the most rapid action of any of the non-depolarizing drugs. It has an intermediate duration of action. It does not cause histamine release. The effect of the competitive antagonist at nicotinic receptor can be terminated by an anticholinergic like neostigmine. Of course, it is given in conjunction with atropine to minimize muscarinic response, as explained before. Neostigmine prevent breakdown of acetylcholine, and therefore concentration of acetylcholine in the neuromuscular junction is increased, and it can compete with the antagonist, the competitive antagonist. Notice neostigmine won't reverse effect of succinylcholine. In fact, if neostigmine is given, it increases the duration of action of succinylcholine. To summarize the mechanism of action of muscle relaxant, normally the sodium channel at nicotinic receptor in the neuromuscular junction is closed. Acetylcholine briefly open it and produce an action potential and therefore muscle contraction. Antagonist at nicotinic receptor in the neuromuscular junction block the receptor and prevent acetylcholine access to the receptor. Therefore, doesn't allow the channel to open. On the other hand, depolarizing muscle relaxant like succinylcholine interact with the receptor and channel is open and remain open, therefore causing depolarizing block as we explained the details in the previous lecture. Antagonists at nicotinic receptor at neuromuscular junction are called non-depolarizing blocker to distinguish them from depolarizing blocker like succinylcholine. In this slide, we summarize the event and site of action, site of drug action at cholinergic synapses. We have described how drug can affect process of synthesis and release of acetylcholine. We have described the effect of drugs which interfere with inactivation of acetylcholine and how they can be useful in some clinical situations. We also covered the treatment of organophosphorus poisoning. We have explained the classification of receptor to nicotinic and muscarinic receptors, introduced selective agonists and antagonists at these receptors and described their action, clinical implication, some of their undesirable effect, and contraindication. Now you are familiar with action of drug on the cholinergic neurons.